Everybody for joining us. Hey, thanks so much, everybody, for joining us for Georgia MemoryNet Insights today in the webinar version. And so we're glad that you could join us today. It's a little bit of a different format. We're going to send you some questions during our presentation today, just before the presentation and after the presentation. And so looking forward to having a great session today. Our speaker today is my boss, and I used to be her boss, but she's my boss now. Carolyn Clevenger is a doctor of nurse practice who is an innovator, a clinician, a speaker, a researcher, and so we're so glad to have her today. She's going to talk about some work that she did with the Alzheimer's Association. She was one of 10 members on a national guideline panel to update the evaluation diagnosis of cognitive impairment in primary care settings, and we thought that was a really appropriate target for today. And so, Carolyn, I think we'll have you share slides. Great, thanks so much. And so a little bit different than before, you're muted. We can unmute you if you want to come on and ask a question. There's also a question and answer box. And so we can actually see questions that you post, and we'll have those be carried out to the end. And if you raise your hand feature, we could see that you're raising your hand. Feel free to use emojis and also respond to poll questions. For the next slide, please.
Oh, lost my mouse, sorry. There you go.
Great. And so this is what we're going to talk about today. And we'll also put in a link in the chat for you to be able to identify kind of where you could find this article. It's free for you to see. And next slide, please. Our accreditation statement. And next slide. Disclosure statement. And so Dr. Clevenger does have a lot of work that she does with national funders as well as industry. And so I, as the course director, have taken a look at the slides today, and you're in for a treat. There is no conflict of interest that I identify through these slides. And next slide. And Kim, I think that now we might launch the pre-questions. And Carolyn, I think you could talk while people are looking at those questions. So feel free to start. Thanks.
Great. Well, thanks everyone for joining. I know many people are mid of their busy clinic day, including my folks here in the next door at IMC. So what we'll do today is a little bit different, I feel like, than what we typically do on GMN. It's a day of different GM insights, but this is more like journal club. So I'm going to walk you through a publication. It's actually a series of publications, but as a co-author and a participant, a co-author on the paper and a participant in the process that created the content that then we were able to publish, give you some behind the scenes kind of experience in how that went, and some just kind of interesting things about the timing. And mostly it's not really me complaining, but it is me sort of sharing what my experience was as a member of this team. So before we get into, and this is the full citation. If you're not familiar, those DOI numbers are always the easiest way, I think, to get to the article. They are free access in the Alzheimer's and Dementia Journal, but this is sort of the what the cover should look like for the paper that I'm primarily going to focus on today, which is the executive summary recommendations for primary care. There are also recommendations for specialist care, and then there's an overview paper that we put as well in this special issue of Alzheimer's and Dementia in December of 2024. Emma, are the questions up and live?
I'm trying to insert it in the chat box.
I can see, I don't think that there's a chat box in the same way that there is in a Zoom meeting. And so in the webinar, I'm going to put some announcements as a question. And so everybody can look at questions that are teed up. So thanks.
Let me know if I should stop sharing so that we can see those.
I think you're good.
Okay. Can I go to the next slide?
Yes, please.
Give the first answer away. If you are looking at your questions already, you'll be ahead of the game, guys. I just wanted to note about the process of doing clinical practice guidelines. And there's a standardized, of course, an evidence-based process that you follow for writing these clinical practice guidelines. And the way that this was convened was really coordinated at its core by the Alzheimer's Association, primarily with Brad Dickerson and Alia Treza, who were co-chairs of this work group. And I still remember where I was when I got the call with the association, and I was sitting at the stoplight of North Druid Hills and Claremont Road, if anybody sort of thinks about that intersection on my way into work. And what they were asking was, you know, we want to do these guidelines on the assessment and evaluation, because what we're hearing is that clinicians aren't taking the initiative or following up on complaints or subjective cognitive decline concerns or reported concerns from someone else, because they don't have a clear guideline on how to work that up. And that's what we're hearing. And I was sort of like, you know, Jim, my work is really in the after workup, and I want to get into care recommendations. And his point to me was that if we don't have good diagnostic evaluation guidelines, then, you know, that sort of doesn't set us up well for recommending the actual practice and the management of patients post-diagnosis, which was a fair point. But my contingency was I'll only work on this if I get to work on the care guidelines next. That was 2017, guys. So I seem to find myself in long-term projects, and not because I'm extraordinarily patient. I think I just happen to fall into these kinds of things. But the process began in 2017. I found some of my older files, even today as I was prepping, and we met on a monthly basis, this group of us. I think we would call this a diverse group in terms of the professionals who were represented on the team. So Brad and Ali are both cognitive neurologists. I'm the geriatric nurse practitioner on the group. There's a health services researcher who I happened to have published with before, but had not personally met in person. So that was a fun experience. A geriatrician, Geri Psych, a Geri Psych NP, and then, of course, this was chaired by the Chief Scientific Officer, Maria Carrillo from the Alzheimer's Association, who's still with the organization. And we did have a contracted group that supported us. I will say that was incredibly helpful. What they were primarily doing, though, was the data, the literature search, and then doing with our guidance in terms of what the inclusion and exclusion criteria should be for which papers we pulled in. And then they would make those available once those met inclusion criteria, and they would help to review and synthesize the evidence. In my, so again, this is just Carolyn's opinion on, you know, how do you make recommendations to evaluate someone who presents with a symptom? It's a standardized process we would use to evaluate any symptom when it comes to us, right? We want to know when it started and what it looks like exactly, and what makes it better and what makes it worse, and does the timing vary? Have you tried any treatments? All of those sorts of things. And so we sort of, those are not necessarily the things that we saw in the literature. What we saw were things like the background. And I think this is an interesting topic in this particular context at GMN, because much of the background that we were reading was about both the population and the patient and caregiver side of things, that they were presenting with symptoms that they felt like were not evaluated, that people who had a diagnosis of dementia on their problem list did not have that disclosed to them. And then on the clinician side, that they were not feeling confident in identifying or following a standardized protocol for evaluating someone's symptoms. And the numbers were not 100% even with neurologists. So, you know, something like 30% of primary care providers felt confident, 71% of neurologists. And so that was really primarily what the literature supported. What we did not have, and this probably speaks to the timeline, was writing support. So we have this team of clinicians and researchers who then are also trying to write this up. And, you know, we had one participant who was part of the previous guidelines from 2011, and he was in the room and he was like, one of the biggest challenges with volunteer committees and work groups, part of your like professional organization or society, is depending on busy clinicians who are then having to do all of the writing. So that's one of the reasons that this took so long. There were other factors, including where we planned to publish, had a very well-known journal I won't name, and then had a big kerfuffle with their editor-in-chief after they had accepted or said they were interested in our query when we queried the editor. So that sort of happened. And then I will tell you, I'm going to show you a big guideline sort of overview. I approved that in my own records and my files as final for publication in January of 2020. So of course we know what happened in March of 2020. And then a lot has happened in the space of Alzheimer's disease specifically, and the science and the availability and the evolution of not only how we diagnose Alzheimer's disease, but how we define Alzheimer's disease. So we were trying to then sort of run with those various changes and to make these continue to be relevant and applicable. We did result in 20 recommendations. Back in 2018, when we met in person, we're like, this is at least 10 papers. Let me tell you, we came up with 2. So, and we feel very successful to have those done. So as I mentioned, it is addressing both primary care and specialty care. We're going to focus on the primary care. I'm going to walk you through the highlights. Oh, look at this. Your pretest.
So this was the question that folks answered before the slide came up this time. And this is the difference between screening for cognitive impairment. And you're about to say the answer.
I am. Thank you so much. That was great timing. So we will focus, like I said, on primary care at a high level. You know, I think every time I go back to the publication and what we finished, I'm really proud of the work. I think you will find so much relevant and very clinically grounded guidance, both on the overall process, and then I'm going to walk through each of the recommendations. You might imagine I'm going to say very minimal about these because this is a presentation and these are slides. You will find the full recommendation and some of the rationale behind those in that paper. And again, I just felt like it was super helpful. So the first thing that we had to agree on was, what do we mean by these clinical practice guidelines to diagnose Alzheimer's disease? In 2017, I feel like I hear it less now, but I do still hear this from lots of clinicians, which is, but the U.S. Preventive Services Task Force says we're not doing screening. That's they don't recommend for or against, basically. And so we got very clear early on that these guidelines apply to a patient who has symptoms. Either you've observed them, someone has observed them, or they've been reported to you by themselves or by someone who is knowledgeable about their day-to-day behavior. I did say this earlier, the process really follows a similar evaluation we would follow for any clinical concern or a complaint, right? What's the history of the illness? What other relevant history may play into my diagnostic evaluation and the way I'm going to synthesize this information? There is a relevant physical exam, which we talk about. What is the contributing data that I might get outside of that exam room that I'm sitting with this patient in, whether that's labs or imaging, other types of testing, all toward, of course, the diagnosis, which you really need to have ahead of creating a treatment plan. I think the thing that's unique about primary care, and I will show you the other algorithms for specialists, just high level briefly, is that, primary care plays this unique role. We know people well. We know the informant who might be presenting or telling us about their symptoms probably most better than a specialist would. We also can incorporate the other things we may have been treating them for over a lifetime or even over the last months and years. So, and these have direct implications for their cognitive performance and their functional performance and their behavioral symptoms. So whether that's a mood disorder, depression, anxiety, whether they've got other conditions like chronic kidney disease, or they've been dealing with sleep apnea, with, maybe not great luck using their CPAP. What other contributory factors occurred in their social life, their occupational experience, what's been happening in their family life, if they're recently grieving, if they've also got substance use disorders, or if they're maybe experiencing the effects of other medications for chronic pain, for example. The nice thing about a clinical practice guideline is that it creates some structure for us. No one is saying that you shouldn't individualize the treatment. And I think who better to do that than primary care, where you have this long-term relationship and you know the patient. This is the figure, by the way, that I approved January 27th, 2020. That's what's in my files. So this was kind of the high level picture. And what I'll say about this particular slide is that it begins and ends with communication and shared decision making. So that's both core 1 and core 7. We begin with establishing what is our goal for pursuing this process. There are certainly barriers on both sides, the professional and the patient side, about why do I even need a diagnosis? What's the value of this? And so understanding what's important to them, what matters most about this process, what maybe matters most to their care partner, who might just be an informant at this stage of the game. And maybe we can also add our own expert and clinical guidance on whether this may open opportunities for different treatments that you would require a diagnosis for. And I'm not just talking about medication treatments. The new GUIDE program that we've spoken about here, and you may be familiar with, you have to have a diagnosis of dementia to get into that program or to have that added benefit. And from there, it does sort of begin with your HPI with the patient and care partner. You're going to do a review of systems that covers systems that may weigh in on their cognitive symptoms. But again, this is the evaluation of cognitive and functional and behavioral, and we added sensory motor here. So you're going to do a deeper dive evaluation of those systems, more so than your larger review of systems. And then taking into account the risk factors that they may have present. Maybe they've got a history of vascular disease. Maybe they have a history of specific cerebrovascular insults. Other things that may affect sort of the brain fog or brain functioning, when we write this in January 2020, we didn't think about long COVID, for example, or more things that we know about like microbiome health and that connection. But again, developmental history, social history, health-related behaviors. Your exam, honestly, is a bit more focused. There is a medical, neurological, and psychiatric exam we would recommend. But the thing that would probably be a bit different is a mental status exam, and we very strongly recommend a validated instrument. So this is more than your annual wellness visit requirement. I know hopefully we're doing more than the minimum of asking someone if they have challenges with thinking or memory. And then in course 6, I think this is where we begin to explain how we synthesize information and what type of a diagnostic determination you would want to make. So if you sort of think about the highest level, basically, does this person have cognitive impairment or not? And is it major or minor? That's sort of step 1. It's possible they're cognitively unimpaired, maybe have some concern. Maybe they have subjective cognitive decline, but not measured. And we've got mild cognitive impairment or dementia or major neurocognitive degeneration. And then step 2 is there a primary cognitive domain that's affected, right? So are they amnestic? And particularly this is helpful if they are still at that MCI stage. And then trying to get to the likely cause or the etiology. The more specific you can be, the better, both for your patient and for your coding, honestly. And I think we started to begin, even at this phase of the recommendations, to understand that this is a multi-step. You're probably not completing this in one visit. This is potentially over multiple visits. And I think you'll get better guidance from groups like GSA. We talk about billing for this using things like the Cognitive Assessment and Care Planning Code, which should sort of help you accommodate the longer time this takes, because it is going to be multiple steps.
Carolyn, I just wanted to remind folks that I can see your hand if you raise your hand for a question, and I'm also watching the question and answer period, and so I'm going to launch the next quiz. Go ahead, Carolyn.
Okay. So this is the algorithm, and if you've got a larger screen like I do, you might be able to answer this question easily. If your screen is smaller, then we're really testing your knowledge. So again, this is just a nice, I think, decision tree or an algorithm to sort of follow for this evaluation process, beginning with whether there's a concern for cognitive and or behavioral symptoms. And even if there is not, we still recommend beginning with that annual wellness visit, your Medicare annual wellness visit. Every one of these algorithms is going to bring you back to promoting brain healthy behaviors. That's true whether the person's cognitively unimpaired or whether they have moderate stage dementia. And then you can still consider referral for brain aging research that may be appropriate in any case. If you're following sort of the algorithm straight down on the left, or the larger, like the majority of the page, you sort of see a following of what we just showed in that larger graph, where we begin to think about your focused exam. And then where you begin to branch off into, do I follow the next step? Do I take the next step? Is a question of where's your confidence level as a clinician? And so if you feel that this person, after these basic steps have been taken, you've gotten your HPI, you've got the systems review in the most relevant systems, you've got your psychosocial history, the risk factors involved, you've done a focused exam, including that mental status exam, and you feel pretty confident that this person is not impaired, then you can go over to say, let's talk about how we maintain your brain, to use the old Alzheimer's Association program language there, and let's make a plan to continue monitoring these. And you might decide that this would be a good thing to reassess in 12 months, or to talk about what to do if symptoms appear that are new or if they worsen. If you feel like this person, this is an interesting way to ask the question, but that you have a high confidence that they're cognitively unimpaired, you would say no. Another way of saying that is that you have high confidence that they are impaired. And then you would move forward with cognitive function specifically. That may require neuropsych testing, whether you have access to digital testing or you have to refer to someone in your community. And then following that, you should get information more specifically about which domains and to what degree they're affected before you move into the cognitive behavioral syndrome. How do we do on the answers to the lab testing? I'm curious. Oh, very nice, guys. Yeah, so you can see we talk about what's called tier 1 testing at this level in primary care, as opposed to tier 2 or all the way up to tier 4 kind of testing. And tier 1 certainly does include that TSH. Nice.
It's very interesting to think about, you could go to a practice and get many of the other tests that are not the right answer for this question. And so I'm curious as to what the committee debated on what became a tier 1 test versus tier 2 versus subsequent.
Yeah, I think we were really, we tried, there are a couple of instances here where we really wanted to talk about what not to do, but that's not how you write guidelines. It's what to do, right? And so the way that we were really trying to address, do not out the gate with someone who doesn't have risk factors, go to like an RPR, for example. And we also know now, this has been an evolution about, for your p-tau217 testing, that's validated for people with a symptom. So that's not these folks necessarily yet. And so that was really about like, let's get to some basics and not overlook the basics and try to sort of reach for things that are just the newest and shiniest. We said the same thing about genetic testing, by the way. So high level, I just kind of broke these into a couple of categories to give you an idea. And I hope that this just sort of like, what's your appetite to look at the full article in and of itself. But to point out that the first 3 steps begin with that core 1, right? This is about communication and shared decision-making, which I think we've mentioned already. That first of all, you initiate an evaluation. That is really critical. I think it's one of the reasons GMN exists, is that we had heard from so many patients who said, I've reported symptoms and I don't feel like an action was taken from that. So number 1 is to initiate the evaluation. And then from there, establishing goals, and then choosing your testing. And this is also about the tier 1 lab testing. We're going to go from least invasive to most invasive, right? So the least narrow, meaning the most broad, and to the most. And we recognize that the options that we have for testing are going to continue to evolve. The second phase is really gathering all of the data that you would gather. So all of the things that we've talked about between history, physical, validated tools for cognitive testing, that first tier lab testing. And we did talk about structural brain imaging. This is just your basic MRI and a CT scan if MRI is not available. That's sort of where we are at this phase. And then your next couple of recommendations focus on more communication and shared decision-making. So as tests come back, you might find that you will have conversations about each one, right? It may be ahead of the test, like what can we expect from this test? What are the risks that risks go into testing as well? And what would we do with the information when we get it back? And then when test results come back, okay, what is the meaning of this? What are the implications? And does this prompt us to do additional testing, or does this basically give us the answers that we want? And we talked about the use of a tool called Spikes, which is your next question. So I'll give you just a moment. I see it. So I'll give you just a moment to respond to the Spikes protocol, which comes from our colleagues in the palliative care field.
Again, feel free to drop any questions that you have in the Q&A area. And I know that if you have something that you need to share with us just to provide information, we can also do that there. Questions that we haven't answered yet will be listed as open. And then here is your poll result.
Perfect. Oh, we've got some palliative care trained folks here. So yes, absolutely, invitation to give information. And this is what the full protocol looks like, right? So we set the stage. I think in this case, if you're having a visit where you're going to disclose a diagnosis, and if they haven't had someone else, I think it's also very helpful to invite them to bring someone along if they would like to have them with them and they haven't been there together. Understanding like what's their understanding. Again, this is probably a multi-step process. So we're not probably beginning from 0 or from scratch. And then you got your invitation to give information. And then you are going to sort of, share your knowledge, right? So this is breaking the bad news itself. Sometimes it's helpful to fire off the warning flag ahead of time. Unfortunately, I have some bad news today to say, so that they kind of have some idea, they've prepped themselves for what's coming. I call the E the shut up part of the Spikes, which is where you are quiet and you let them express emotion. And express your empathy to that emotion. And then the S is like more like the next steps, right? So what are going to be the next steps, understanding this, and where do we go from here? For your last set of recommendations, I'm grouping them all together because these are the recommendations that get into when to refer and what you can expect from the specialty referral. So generally speaking, we talk about when this patient has an atypical presentation, anytime you are uncertain in how to interpret the results that you're getting, younger onset or rapid progression. And then in the specialty recommendations, you certainly will see, well, you might have these options in primary care. You certainly see these in specialty and subspecialty. just to give you at a high level, again, an idea of the algorithm difference in the specialist recommendations, and this is more general neurology, psychiatry, geriatrics, you do begin to see a little bit more jumping into some of these additional tests, including getting up into your tier 2s and up to tier 4 testing. And again, if at this level, the confidence is not there in the diagnosis, you've got the subspecialist setting, which looks probably the most different to how this begins. Because really, when we're bringing the subspecialist in, we've gathered all the data. We've got a nice package, hopefully, for them to make some determinations. And then if there's any additional testing needed, this is where in the guidelines anyway, the things like FDG PET came in, amyloid PET, I think probably more commonly now, and then where they go from there. Their also treatment plans are maybe different than what we're going to be able to offer in primary care. So high-level journal club review. I just wanted to say, if you take away anything from today, these are my 3 points for you. Well, I first should say fourth, please read the article and please share it. But the first idea is that clear action that's evident to the patient should occur when you observe or you have reported symptoms. I think in this audience, that's what we're all here for. So that's probably an easy sell. I'm preaching to the choir. I get that. I also want to remind you that the majority of recommendations are focused on primary care. And so I know many times people are sort of like, when I present to groups, the general primary care, the only question I get is, do you accept referrals? And I know that can certainly be helpful. And I know there are many of us who don't feel confident in this space if you don't do it all of the time. But I think these guidelines you can get a lot of ground covered for many patients by doing this in the practice that they already know and trust. And then the last thing I'll say is it took us 8 years to publish these guidelines. Let's not let it take another 17 to implement. Of course, 17 years being average time from publication of evidence to implementation. But you only will see improvement in this diagnostic, timely and accurate diagnosis actually getting done at a higher level if we're actually sharing and implementing these guidelines. Writing them is not the work. Doing it is the work. And we could do the post-test, but I feel like we've addressed our questions, Dr. Johnson. Do we have any questions for the Q&A?
No, I think so too. And I'm going to be able to post the link to the article in the question and answer, because that was the first question. So let me see if I can do that.
That's a good sign.
And so if you go to questions that are answered, you'll be able to see that link for the article. I did have a chance to read the article. It's informative. I think that, it's been too long since we've had these types of guidelines before. Again, thanks for coming today. We will continue to look for hands that are raised. I can unmute people if you'd like to go live and ask a question. And then here's the way in which you go ahead and get credit for participating in today's webinar. It's 21641. If you text that to that number, you can do that there. So thanks so much. And just one more check of everybody that's in the room. No additional questions. Hey, thanks so much, Dr. Clevenger. Really appreciate it. Thanks so much, everybody, for joining. We'll have this put into our recordings online so that you can see this and other talks that you might have missed. So thanks again for coming, and appreciate you. Have a great day.